Thanks a lot, Gene. I want to thank the AIM organization for organizing this. Thanks to everyone for coming today. It's really wonderful to see so many people here. Jen and Rhoda have done a great job organizing this, along with Gene and the AIM organization, for which we've had really wonderful interactions over the years. They've had, you saw the walk notice. Judy Sagar is organizing the walk. It's just always a lot of fun. So, and very helpful to our mission. So today I'm going to talk to you about the immune response against melanoma. I'm sure you've heard some about it already in the adjuvant talk with Rhoda, but we're going to talk about how we can utilize the immune system to fight cancer. And we really love immune cells because they live in the body for a long time. When you get your vaccines as a kid, you never get them again, and yet you still don't get polio or measles or anything. And that's because cells that are stimulated, they're called lymphocytes, live in the body for many, many years, 70 years or more in the body. They're actually produced, a lot produced around the time of puberty and before, and then they just live in the body. So that's why if we can activate those cells, keep them in the body, we can get long, durable responses, which is, in the end, what every patient wants. So to combat melanoma, because it goes everywhere, it can go everywhere, we need to fight it with something that goes everywhere. So lymphocytes circulate in the blood, and so they can go to all parts of the body, attacking the melanoma where the melanoma is. So we're really fortunate that a few years ago we only had 2 drugs that went throughout the body, one a chemotherapy and one an immunotherapy. But now I'm sure you've heard all about it. You just heard about the targeted therapies. We have a lot of new drugs which we're extremely excited about. Many of these drugs are targeted agents and the others are immunoagents. And so they're stimulating the body's immune system. So this has really given us a great toolbox. What we're excited about, though, is not only this, but the pipeline of drugs that we see coming down the pike. Every couple of months we get a new drug, and we see, I think this is just the tip of the iceberg. I think we're going to see a lot more drugs in the near future that we're going to have for melanoma. Now, the immune system can be very complicated. You hear about all these different approaches, vaccines, antibodies, and then they name each drug 3 times, like anti-CTLA-4 turned to Ipilimumab, and then all of a sudden I turned around, it was called Yervoy. And so, so it gets extremely confusing, even to scientists and doctors, because all the nomenclature around. But this is all based on all of the immune therapies, actually a very, very simple premise. One simple premise. And that is what we're trying to do in the end is get this cell, a cytotoxic T-lymphocyte, this cell in the body that we evolved to fight viruses, but now we're trying to get it to fight cancer, to recognize a tumor cell. And once it recognizes, it does what we call a kiss of death. It releases enzymes to then poke holes in the membrane of this, and then the cell undergoes what's called apoptosis, which just pretty much means die. And so what we want, and then the immune cell goes to another tumor cell, does the same thing, goes to another tumor cell, goes the same thing, goes to another tumor cell, does the same thing. So in the end, all we want are a lot of these T cells in the body to kill the tumor cell. So all of these complicated immunology drugs and approaches can be boiled down to this. We want more T cells in your body to kill the tumor. That's as simple as that. So the first approach is called a vaccine. Vaccines work by making these T cells inside the body, by putting what's called an antigen to mimic the tumor and to teach the tumor, it actually gets taught in these lymph nodes, teaches the T cells what the tumor looks like so the T cells can proliferate, there's these little red things, proliferate and go throughout the body, inside the body. So it's something we usually inject in the arm or the leg, something that looks like the tumor to generate a bunch of T cells in the tumor. So that's called a vaccine. We did do a study a few years ago of interleukin-2 versus interleukin-2 plus a vaccine, and we did see more responses when we added the vaccine and better progression-free survival when we added the vaccine. Now that's an early stage vaccine. Now vaccines have improved a lot, and we have a lot of new studies looking at vaccines. So the advantage of the vaccine is that it's off the shelf, and it could be many patients in different hospitals could potentially get it if we can get it to work. But it's still in investigational stages, and we have to really add things to the vaccine to make it as potent as possible. But this is an example of someone who had a tumor on the head. He got a vaccine in the arm by Dick Royal, one of our surgeons who's running this study, got the vaccine in the arm, and then the tumor in the head went away because we stimulated immune cells that then went through the bloodstream to the scalp and eliminated that tumor. So that's what we're trying to do. It's a very low toxicity type treatment. And we're trying to make less toxic, more effective therapies. And so our hope is that if we can continue to work on this, that will be something that we can use in the future, especially for stage 3 disease, earlier stage disease. So next I want to talk about the antibodies. You've heard a lot about these. You just have to pick up the newspaper these days and you hear about these drugs. They're based on the premise that our immune cells, those lymphocytes I talked to you about, you can think about those like they're tanks circulating the body. They're here to protect us against all the viruses and bacteria that are in the environment. They're very dangerous too, because I know all of you probably know somebody with an autoimmune disease like rheumatoid arthritis or lupus. So these lymphocytes can also, unchecked, be dangerous to us. So our body has been smart and put on brakes onto these cells, and these antibodies simply remove the brakes, and then they unleash the power of these circulating tanks that we have in our body. And so Jim Allison started that. Jim works here now. Started this approach by using the first drug, Yervoy, called anti-CTLA-4 initially, to take that brake off, to unleash the immune system. And these drugs then allow the T cells to kill the tumor cells. So the first study that was positive, a randomized, one of the first randomized studies in metastatic melanoma that was positive was anti-CTLA-4, Ipilimumab, I'll call it Ipilimumab, versus the controls, and did show better survival and progression-free survival, and for that it's now standard. We prescribe it all the time in the clinic. Now, you can see there's still a lot of improvement above Yervoy that's necessary. And this is, new studies are coming out all the time. The study just came out this year showing the Ipilimumab plus Dacarbazine chemotherapy versus Dacarbazine alone. So multiple studies now randomized showing a survival difference. This is one of my patients who we know now, since it was so long ago that we started these studies, that we can get very durable responses from this. And this is what everyone wants, a durable response. So you can activate the immune cells. When you can get that to work, then patients can do well for a very long time. And so this is one of my patients, Terry Mueller, who we treated with a bunch of stuff and then finally gave him Ipilimumab 7 years ago, and he's doing great today. So if you see Terry, tell him I gave him a little PR. All right. So there are other breaking molecules, as we talked about, and so a few years ago we started working with this pathway. Now I wanted to show you how this works. PD-1 is another break on the T cells, but it binds to this other molecule, PD-L1. So you can have an antibody against this or that, and it doesn't matter. As long as you break up that party there, that then everything's good, right? So that's why sometimes it gets confusing and you see anti-PD-1 or you see anti-PD-L1, but they're essentially doing the same thing. They're just blocking this pathway. And so this is anti-PD-1. That we had some really great responses initially, and this is the tumor regression that was seen. This is one of my patients who had disease everywhere, including the brain, and we resected that, and he had, this is disease near the pancreas, and then slowly everything went away. Sometimes it takes a while. We treated this person for 2 years, and it took months for all the disease to go away. Sometimes the immune system just takes a little time, but now it's been several years, and I only get to see him because his son goes to Rice, so occasionally he comes and comes into town, and I get to have dinner with him. So now there have been a lot of randomized studies showing this drug, again, many different names for these drugs. Anti-PD-1, one of them is called Nivolumab, the other one's Pembrolizumab. Those are the FDA approved anti-PD-1s, but there are many other anti-PD-1, anti-PD-L1s in the pipeline. Every company now has their own anti-PD-1, anti-PD-L1 almost, and they're doing this now for not just melanoma, but other kinds of cancers. So this is a study of the anti-PD-1 versus Dacarbazine, and this is a progression-free survival and survival. These are just coming out. And then if you progress on the Ipilimumab, they show that the anti-PD-1, the Pembrolizumab, still works. So this is 2 different doses of the anti-PD-1 in patients who progressed on the Ipilimumab. So that's a good finding. And then it seems that the anti-PD-1 is a bit more effective than the anti-CTLA-4 if you go single agent. Now, I think the best way to go is combining agents together, as we'll talk about. But if you do single agents, the anti-PD-1 class of agents seems to be better than anti-CTLA-4 head-to-head, and is also less toxic. So rarely do you get that in cancer therapeutics, something that's actually more effective and less toxic. But in this case, that's what we're seeing, which is really wonderful. And quite frankly, being in the field almost 30 years, that was a surprise to me that we would have something less toxic and more effective. So it's really a fantastic. Anti-PD-1 is a wonderful class of agents. It's probably what I would want, front line if I got melanoma. So then the other approach is to actually generate these T cells themselves and then give them back directly to patients. We learned a long time ago when I was working with Steve Rosenberg, Dr. Wargo also worked with Steve Rosenberg, that there are immune cells in tumors trying to kill the tumors, but obviously not doing a good enough job because those tumors are still growing. So we learned to take those T cells out of the tumors, grow them to very large numbers, and give them back. We do that in collaboration with our surgeons and pathologists, and we call that TIL therapy, tumor infiltrating lymphocyte therapy. And we've had some really great successes with that. We have patients with disease everywhere having wonderful responses. This patient we even lost touch with for many years. She lost her insurance, went to Alaska, went to Colorado. Finally, we tracked her down. She's a first grade school teacher in Colorado now and just doing great. Here's another patient who failed many agents and then went on to TIL therapy, did fantastic, and is still doing really well. We had a party at my house this summer with him, and he came out and met all the lab people. It was really fantastic. So our response rate's about between 40 and 50% to T cell therapy. We're excited about this. In the future, we're trying to put genes. We've treated a couple patients now with genes in the T cells that help them actually home and migrate to the tumor. And then we also have some genes in the T cells that help put armor on the tumor so that they can survive in the nasty microenvironment that the tumor makes. So that's called the TGF-beta dominant negative receptor, but don't worry about that name. So we've had some nice nice survival curves for our T cell study. And this is an example of a patient who did really well, had disease throughout the body, and has just done extremely well. Through the years, we've become good friends with him and his family. It's been 5 years now. He went through, we treated him when he was in high school. He's now through college. He now started his first job. And he wrote a book about his experience, and so it's available on Amazon.com. But we're really lucky to have his mother right there behind the camera, Sherry. And so, Sherry, raise your hand. Yes. Yeah. And Sherry said she brought some books. If anyone wants them, find her after the talks, and she can give you one. So thanks, Sherry, for coming and bringing those books. It's a very inspirational story. So what we're doing now is moving beyond this to antibody combinations and antibody combinations and immune combinations with what you heard Dr. Davis just talk about, targeted therapy. I think in the end, we can't silo off into these different fields. We got to work together and put therapies together. This was a mouse study showing that the combination of the anti-CTLA-4 and anti-PD-1 works much better. And that was done by Michael Curran, who also works now here at MD Anderson. And in the initial studies, just dramatic responses, and this is just the waterfall plot, just dramatic responses there, and it clearly shows that, number one, it shows that mouse modeling works, that if you do it right, it really does help us. And the randomized studies now are coming out. This is the anti-PD-1 plus anti-CTLA-4 versus the anti-CTLA-4 by itself, and you can see such a huge difference. And there is, now we want to talk about toxicity. These antibodies, anti-PD-1 tends to have less toxicity than anti-CTLA-4, but they all have toxicities, and the combinations definitely have toxicities. So if anyone's on these antibodies, you have to be really with someone who's experienced in giving these, and you have to be in close contact if there's anything that happens, like cramping or diarrhea, because anything with an itis can happen with these antibodies. Colitis is one of the ones we really have to hop on. That can cause abdominal cramping and diarrhea. And this combination of the anti-PD-1, anti-CTLA-4, even though it was much more effective, and we use it experimentally all the time now, it did have more colitis than the Ipilimumab by itself, also more hepatitis, and so that's the liver function. So when we have patients on this, we unfortunately tell them not to drink anything, and they say, "Can I have one glass of wine?" And you usually say no. So we're not doing that just to be party poopers. It actually is important to protect the liver while you're getting these treatments. And so finally, I just want to close by showing you the triple randomized study that was just presented. That was the PD-1 plus anti-CTLA-4 versus either one by itself. And it does look like the combination is a bit better than the anti-PD-1 by itself. And that seemed to be in a specific population. That benefit was when the tumors didn't have an immune attack, called PD-L1 negative tumors. That's when the immune system wasn't quite in the tumors. Those patients were the ones that really benefited from that combination. So we're not ready for this yet in terms of using that to guide our treatment, but I could see one day looking at the tumors and trying to figure out, Dr. Wargo will talk to you a lot about these biopsies. Well, is this someone who should get the combination or should get the single agent? I think one day that will happen. But we're real excited. This is a pipeline of, these take the brakes off the immune system. These put the gas pedal on the immune system. They're all coming down the pike. We have trials planned on many of these. So we're real excited. And then we really have to bring these silos together. That's where we're very fortunate to have Dr. Davis, Dr. Woodman, other targeted therapy experts in our group, so we can work together to try to put these targeted agents along with immune agents, which is really, I think, going to be part of the secret sauce to what we're doing. And at MD Anderson, we're lucky that we have strong immunologists and strong targeted therapy science to try to put those together. So behind the scenes, there's, you go to Hollywood, you can see a behind the scenes tour. But, here there's also, you go to the clinic, but there's also, you could do a behind the scenes tour of MD Anderson. There's huge amounts. I mean, it takes more people than Disney World, really, behind the scenes to make what you see happen, to see therapies like TIL therapy get into patients. There's so many people behind that. So we're fortunate to have an incredible team here at MD Anderson. All right, thanks a lot for your attention.